The title of today's presentation is Substance Use Disorder Assessment and Screening. These are from slides created by Dr. Lindsay and Dr. Bott of UNM's ASAP clinic. So if you all do have any particularly clever questions about the presentation, I may punt it to them. So our objectives today are to appreciate the importance of screening for substance use disorders and co-occurring psychiatric illnesses. We'll go over the recommended models for screening and assessment, and we'll briefly review common screening tools for use in a primary care and also a specialty setting. So in terms of the epidemiology of substance use disorders, this data is a little bit older, but proportionally it's still pretty representative of where we're at in 2024. We're still, sorting out what happened during the pandemic and the consequences. But the big takeaway here is we have plenty of reason to be worried about substance use disorders, about the prevalence, and as we'll talk about today, about being able to reach patients where they're at accessibly before maybe preliminary symptoms turn into a full-blown substance use disorder, and certainly being able to reach people who do have substance use disorders and connect them to treatment. In terms of specialty addiction treatment, you can see quite a lot of people, almost 10% need treatment for substance use disorders. Around 10% actually receive the specialty treatment, and 1% in the US seek specialty addiction treatment annually. There's a lot of reasons for these discrepancies. A really, really big one is stigma. Most people are not, excited at the prospect of seeking out an addiction clinic. There's a lot of stigma that surrounds that process and the participation. And then, of course, cost, lack of interest, lack of availability. Everybody here probably knows that, access to services here in New Mexico can be difficult, particularly in rural and frontier communities. And that's often where those services are needed the most. Now, primary care, on the other hand, is a place where we can catch a lot more of the population, and they're more comfortable there, which is an important point. So more than 80% of adults and more than 90% of children see a healthcare professional. More than half of 1 billion office visits are in primary care. There's also 130 million on the emergency department side. But a point we really want to make here, and I think it's especially salient for our participants for this particular echo, is that primary care is a place where it's not just that people are more likely to show up, it's also that they're more comfortable. They're more likely to have an established relationship and to feel more at ease in this setting, and therefore may be more receptive to treatment if it's indicated. So this is a somewhat unique opportunity. Medical settings allow us to reach out to people with substance use disorders or with prodromal symptoms who otherwise might never actually go out of their way to see a specialty addictions treatment clinic. And it also helps us to catch people early on at a sort of before they get to a fork in the path in terms of having milder substance use problems. They don't need specialty treatment, but we want to support them where they're at to make sure that they don't require specialty treatment down the line. So screening and assessment is all about what is the best way to reach these patients, to identify them, and to make sure we're directing them to an appropriate level of care. So screening and assessment tools are a great objective way to help us as providers understand what the patient's needs are and make sure that we're calibrating the services appropriately to meet those needs. It also importantly helps us to track symptoms over time so that we can see if the treatment trajectory is not proceeding as we would expect, that we can adjust treatment accordingly, and that's very much best practice. So historically speaking, the models for substance use disorder care used to be very much complications driven. So that was about, somebody shows up with a high acuity issue. There's not necessarily any previous diagnosis. The treatment is usually comprised of addressing specifically those complications. You can think of it as that adage about treating the symptoms rather than the cause. There often is no further support after treating that acute incident. As is often the case, there's a relapse and the cycle begins again. So that's without a diagnosis, just treating whatever the symptoms are as they present. A somewhat more advanced model is the diagnosis and program-driven treatment. So there we do have a diagnosis, that's very important. But still, these people are sort of filtering through just program, aftercare, and relapse with very little individualization. So it is more structured and it does have a better process flow to identify people further ahead of time and scale treatment. It still, to some extent, is based on that acuity model rather than a more comprehensive, long-term, sustainable model of treatment. So what we've moved to now, or certainly what we're all trying to move towards, is a more client-directed and outcome-informed treatment. So that starts with a whole person biopsychosocial assessment that's very much patient driven. So if you've seen our team approach presentation, you know that it's all about the patient being the captain of the ship and that that's very predictive of better outcomes. That it's going to engage information about problems and priorities, that there's going to be a biopsychosocial treatment plan that's driven by the results of the screeners and the assessments that are relevant, and that's going to help us match the patient to the level of service that they need. And then there's going to be regular monitoring of treatment. How are they progressing in treatment? How does it need to be adjusted if they're not making the progress that we would expect? So, where do we start with that? What's the launch point? In terms of conceptualizing how patients move through these systems, it's important to understand what we mean by an episode of care. So that's defined as the set of services that's provided to treat a clinical condition or procedure. And that can range from a month to 4 months typically in duration. And at different junctures, you're going to reassess and you're going to say, is this patient progressing as we would expect? Do we need to adjust treatment? Do we need to change treatment entirely? And that's part of the importance of those assessments where we're monitoring the symptoms as well as their progress. In terms of the continuum of care, that's about the different transition points between, for example, acute care settings or inpatient to all the way out to the community, peer support based. And that's in reference to the severity of the presenting issues and needs. That can also sometimes refer to transitions from a stage of care to another one within a single service. The example, that we're probably most familiar with here being pain clinic to substance use clinic. So in terms of conceptualizing risk, it's helpful to remember when we're talking about screening in particular, that the vast majority of patients, a little more than 3/4, there's not going to be any need for intervention. And what we definitely don't want to do is to give services to people who don't need it, because as we'll see shortly, that's absolutely unhelpful. But we do want to make sure that we're accurately classifying people who may be able to benefit from brief intervention or referral to treatment. So again, in terms of the conceptualization, only the top 5%, the tip of that pyramid, are really going to be appropriate to refer to specialty treatment. But then about 8% could benefit from brief treatment, and around 9% are in that risky category where you want to really flexibly evaluate and see, do we move forward with just a brief intervention here? What's the next fork in the decision path in terms of where these patients go to make sure that they're appropriately supported? And we have the numbers across the top there that correspond to what constitutes risky based on a couple of the screening and assessment measures that we'll discuss in a moment. So one of the most helpful things I would say in terms of matching patients to the appropriate level of treatment with these screening items that we'll talk about are the American Society of Addiction Medicine's criteria. And this is compatible with DSM-5. It is very user-friendly, which I appreciate. Not all similar programs are. And they do have population-specific sections, for example, with people involved with the criminal justice system or older adults, which can be very helpful. New Mexico is one of many states who use the ASAM criteria, and many payers and providers actually rely on this system. So we'll look a little more closely at what ASAM does that's different than what we used to do, because it's a really good example of that more whole person biopsychosocial assessment. So it starts with screening. As we're talking about, this is an important way to identify people at the beginning in terms of where we can move them through the system that will be most helpful. Then from diagnosis and assessment of severity, we're going to look at a very comprehensive set of indices for readiness and relapse potential. That includes not just, sort of explicit symptoms like intoxication and withdrawal, and those biomedical, for example, co-occurring or underlying conditions, but also their emotional and behavioral spectrum. What is the recovery environment? Because this is so important to make sure that we're not going back to those older models where we were accidentally sending patients through a revolving door back into an environment that's really unhelpful for their recovery. And then similarly, relapse potential and very importantly, their treatment acceptance or resistance, because that's going to be a really important determinant about what level of care is going to be right for them. And that in turn brings us to the decision rule part of what level of care is going to work best for that individual patient, all the way from outpatient up to medically managed intensive inpatient. So this is just really a spectrum for reference in terms of that spectrum of care, and something that I do want to acknowledge because it's particularly important in New Mexico is that when we think of how to best move patients through those different levels of care, maybe from the acute detox all the way through outpatient, it may be that we're using all the right screeners and that we're getting good information, but that actually accessing the services is the stopping point. And I am probably preaching to the choir when I say, it can be very hard to find beds, for example. The higher the acuity level of care, the harder it can be to match that patient to the level of care that they actually need. So I do want to acknowledge, this is very much best practice to consider all of these. And also sometimes as providers, we need to do the best that we can with what we have in terms of what's available. Again, this is particularly true in rural or frontier communities. In terms of the importance of matching patients to the appropriate levels of care, this is a great a graphic that kind of represents very concretely what a difference it makes in terms of patients just being willing to show up to treatment when they're appropriately matched. So the red bar being a mismatch between their symptoms and their level of care, the tan bar being well matched. And as you can see, no-shows are significantly higher in the mismatch conditions. And I think sometimes people assume that having, more care rather than less care in terms of that matching would be better. And that's actually not what the data indicates. Patients can definitely become frustrated if they're feeling like they're getting more services than they need. And they often sense that even if that may not be how they explicitly explain it to themselves. But they'll vote with their feet and not show up if the treatment isn't a good match for where they're at. So that again goes to the importance of the screening and assessment. Similarly here, this is over a course of time, so percent dropout at 3-month follow-up with the addiction severity index subscales. The higher the better here because this is about dropout improvement and step down. And on the step down side, if you see the green bar being step down, you can see a significantly higher proportion of the patients who were matched were ready for that step down process, which is the ideal scenario, right? We want to make sure that they are feeling ready to move down to a less intensive level of care when it's recommended on the provider side. So again, this is all just to preface the importance of screening and assessment to be able to match a patient flexibly, but also to the degree that it's possible objectively to the level of care that's best suited to them as a whole person in that biopsychosocial conceptualization. So some things that are really helpful about ASAM, the long-term research has shown great face validity, reliability, and feasibility. And it's helpful for us for identifying both undermatching and overmatching, which, as we just noted, neither of those are ideal, and it's really helpful to know which one it is to allow us to calibrate what the appropriate level of care is as available. So we'll turn now to a very well-known screener, the SBIRT, Screening, Brief Interventional, and Referral to Treatment model. Uh, in terms of the screening portion, what we're doing with SBIRT is just assessing for risky substance use behavior and using a standardized screening tool. So for a lot of people who work in standardized care or primary care and are trying to do what we're talking about here, identifying people who might be at risk. If they're just asking general questions, they're a lot less likely to be able to accurately identify who's at risk than when they use these standardized measures. And what's great about SBIRT is that it really is adapted to use in any healthcare setting. After the screening portion, if a brief intervention is indicated, there's a few different ways to do it, but the idea is that you're just trying to generally engage the patient in a short conversation that's going to highlight to what degree or in what way their substance use behavior may be risky, and to provide some standardized feedback about their current use just to help them understand kind of where they're at on the spectrum of substance use. And then, as indicated, referring them to treatment at a level of treatment that's matched to the screening tool that you've used or the ASAM criteria. So again, there are different ways to do SBIRT. It's somewhat flexible. There's a lot of great videos on SBIRT online, and there's a link to the SBIRT app here at the bottom. But the main idea, people often mix this up with MI or MET, motivational interviewing or motivational enhancement therapy, and there are elements of those involved, but it's not synonymous, and that's important to remember. Because you're starting out with providing information and feedback based on their screening results. This can be especially helpful for high school and college students where there's a lot of cultural normalization around how much drinking, for example, is normal. So they'll use their peer reference group, and if they have a heavy drinking peer reference group, then they're often very surprised to find out that the amount they're drinking is significantly more than most other people their age. Then you engage them in a little discussion about their point of view of their use, coaching them to change their perceptions about their use. This again is where it's a little different from MI because it's a bit more directive. You do, much as with motivational interviewing, ask them to talk about, has this been inconvenient for you anyway? Have there been any problems associated with it to sort of bring that potential for change to the surface? And then again, differently from MI, you're being more directed because you're actually advising the patient clearly but respectfully that, in your opinion, as the provider, it would be helpful for them to decrease or to abstain from substances. You do wanna make sure that in that case, you're teaching behavior change skills that are gonna help them to make that transition, and you wanna make sure that you establish a method for follow-up with a patient. That last step often gets lost, and that's a really important part of it because it could be that you're just starting the conversation then, and the person may feel a little recalcitrant or defensive, which is totally understandable even with the best of expert, appliers. But it may be that it sort of starts the seed for them and then they're willing to follow up on it later with a longer conversation. So you want to be available for that or make somebody available for it. So again, just conceptualizing that as how we're going to reach people at different levels of that risk spectrum. In terms of low risk or no further intervention, that actually is a great place if you're in behavioral health and you're familiar with solution focused therapy. This is one of those classic kind of just ask them how it is that they're doing well. How are they, if they're adolescents, how are they resisting peer pressure? Or, what are the healthy things that you do to help you keep from drinking, for example? So that's a great place if people are already doing well to just help them to reinforce the reasons they're doing well. And then, as we discussed, moderate to high to severe risk means we're moving from brief intervention to treatment to referral to specialty treatment. All right. In terms of screening, we're going to look more specifically at types of screeners now. Again, the overall purpose is that we're targeting an unhealthy or problematic substance use behavior, and we're trying to detect the entire spectrum of unhealthy use to make sure that we're able to refer appropriately to treatment. And as we talked about before, being able to appropriately match the level of severity to treatment is going to dramatically increase the positive outcomes. So first, let's just distinguish screening from assessment. I know those can get mixed up easily. Screening is just the more general form, so it's going to be very high sensitivity, so to speak. It's going to catch a lot of fish in its net because these are just relatively short questionnaires that are going to identify people who may be at risk. They're adapted to be used in a variety of settings. Most of them are adapted so that you can just engage in a brief intervention simply with the screener itself and say, this is how this compares to other, people in this population, et cetera. And again, really helpful for tracking symptoms over time. Assessment is much more in depth. So an assessment is going to be much more specific. And so that's much more about where are they at on the spectrum, specifically what type and approaches of care are going to be most helpful. And it's going to be much more collaborative and much more dimensional. So the main thing there, we're certainly looking to rule out or establish the presence or absence of a co-occurring disorder, and very importantly, determine the individual's readiness for change so that we can support them appropriately with matching to them to the level of care. Also, something that can get lost with assessment, but is very important, is identifying the individual's strengths as well as their vulnerabilities, because this is going to be an important predictor for the trajectory of their treatment and recovery. So some of the common screening tools for both adolescents and adults with substance use disorder, the CAGE questionnaire we'll look at briefly, which is alcohol specific. The CRAFT, that stands for car, relax, alone, forget, friends, trouble. So it's targeting those, have you used in the car? Do you use it to relax? Do you use it alone? Have you ever forgotten what you're doing when you use? Do your friends and family ever worry about your use? And have you ever gotten in trouble because of your use? One of those clever acronyms where that's literally what the inventory is about, and you can see how it's especially helpful for adolescents. The alcohol use disorder, the audit, that's of course alcohol specific. The DOST is the drug abuse screening test. And then NM Assist, you might think that's New Mexico, but it's not. It's a NIDA modified assist, and that's a great one because it's actually interactive. You can do it online and go through it with the patient. It has the little decision forks built in. And then we'll talk briefly also about the cows, the SIWA, and the utilization of urine drug analysis. So the CAGE, this is a little old school. It's 4 screening questions. Just 2+ score suggests a lifetime diagnosis of substance use disorder. And I will say that even though this is very often just used as a preliminary screener in primary health settings, I have found this particular conceptualization to be really helpful for psychoeducation. So for example, when I used to work in an alcohol and drug program on a university campus, we used exactly this graphic to educate students about what actually a standard drink is, because very often they're drinking in formats that, they're not usually using a standard wine glass if they're drinking wine. And this can be really helpful for helping them to understand the discrepancy between what we would consider a typical amount to drink in a typical amount of time versus how they're actually consuming it. So useful as a psychoeducational tool in addition to useful as a screener. CAGE stands for ever felt you should cut down on your drinking, people have been annoyed or criticizing your drinking, have you ever felt guilty about your drinking, or have you ever had an eye opener for a drink first thing in the morning? So you can see these are really big picture questions that help you to identify lifetime if this person may have had an alcohol use disposition disorder. Let's see. So in terms of the audit, I think the audit is really helpful. This is not one that you start with, so it's not the most preliminary screener, but if prior questioning or screenings have indicated that there may be an issue, this helps you to hone in on the severity. So the audit C is just a modified, it's just the first 3 questions. We'll take a look at that now. And these just indicate whether they're drinking or they're increasing their drinking to a higher risk level. So the first 3, the audit C being just how often do you have a drink, how many units of alcohol, and how often have you had 6 or more or 8 or more as a male on a single occasion. So looking at binge drinking and then daily drinking. The drug abuse screening test, very similar. This is really just looking at kind of frequency and to some extent severity, and it's in this binary format, no or yes, which I find is very helpful with patients who get frustrated with a whole lot of screeners. It's a lot faster for them to go through and much more straightforward than many of the others. The NIDA modified assist, like I said, this is one that's web-based and interactive, and so that's really helpful because it helps you to get to the criteria that are specific to that patient while they're in the office with you, so you can have that real-time conversation with them. And we have the link there. That's one I really encourage you all to check out if you're trying to integrate these tools in your setting. It's pretty straightforward, and there's a lot of backup, so to speak, if you do get confused. In terms of the clinical opiate withdrawal scale and the clinical institute withdrawal and alcohol scale, these are ones that I know are gone over in much more detail in some of our other lectures, but these really are just symptom trackers. So again, that's helping you to evaluate progress during treatment. And then I think it's Dr. Warwick does a presentation that discusses the utilization of urine drug analyses as another form of screening of helping us to monitor treatment and see, specifically what type of substances may be being used and how patients are progressing through treatment in that specific measurement sense. In terms of mental health screening instruments, some of the most common ones, there's the World Health Organization's quality of life inventory, and that's a really nice big picture kind of snapshot of the overall quality of life and general health. Then the PSQ, the Patient Stress Questionnaire, that integrates some of the most common screens for behavioral health symptoms. So that's a combination of the PHQ-9, which we use for screening for depression, GAD-7 for anxiety, PCPTSD for patients with a trauma history. And then the HUDAS, I think, is the World Health Organization's disability assessment schedule. And then again, the quality of life. And we have a link here because all the ones that we're naming here on this screen are public domain via SAMHSA. So it's really helpful to be able to just download those, and they're pretty straightforward. They all have instructions on them about how to code them. Now briefly, we'll turn to assessments. The components of a comprehensive assessment include, just like we were talking about at the beginning, that kind of whole person biopsychosocial portrait. And again, it's really going to be driven by the patient and ideally by their collateral as well. So talking to friends or families or people who comprise their main psychosocial environment. And as we talk about in team-based approach, there's that importance of an interdisciplinary approach to incorporate everybody's perspective and recommendations. Some of the most common assessments in this field are the Addiction Severity Index, that's semi-structured interview, the Brief Symptom Inventory, and that's about psychological distress or the detection of a possible psychiatric disorder, and then Timeline Follow Back, that's mostly for research purposes, as are many of the ones at the bottom here. So if you know about those, you already know more about them perhaps than I do.